Mathew. She is an associate professor in the Department of Psychiatry, London Medical College, Toronto. And she has done, her foundation was in palliative medicine as well. She is in charge of palliative care clinic as well as suicide prevention clinic at Medical College, Toronto. She is an assistant editor of Kerala Psychiatry Journal, and she is in the um, executive committee of uh, Executive Committee of Kerala State Branch of Indian Psychiatric Association. She has a PhD, and the topic was prediction model for attempted suicide among adolescents and adults. Uh, she has also published in peer-reviewed journals, and she's helping us in seeing patients with mental health issues. So, welcome, Dr. Anju.
हमें हाँ
You can call.
Dr. Anju, are you there?
I guess so. She has left right now.
Okay, probably the problem.
We
Anybody?
Good evening, sir. Sunil, sir.
കേൾക്കാം.
ഇടയ്ക്ക് ബ്രേക്ക് ആയിപ്പോയി. ഇപ്പം കാണുകയൊക്കെ ചെയ്യാറില്ലോ അല്ലേ?
I think your internet might be unstable, so that's why sometimes the voice is missing.
ma'am, you can switch off your video and try speaking, ma'am.
Sure. But my audio is breaking. ഇങ്ങോട്ട് പറയുന്നതേ it is breaking. Let me see. Video of it.
Is it okay now, ma'am? Is it still breaking our audio?
This is better.
Your voice is also clear, ma'am.
Okay. Fine.
So we can go to the topics for today. So if you have any doubts regarding the anxiety, depression, and delirium, I would like you to come up with your queries.
This is, let me just clarify. This is just a group of doctors and...
Yeah, so there, here we have only doctors, and they have already gone through some modules on anxiety, depression, delirium. So they have the basic knowledge, and we are asking whether they have any doubts in the module or anything they want to clarify.
Okay.
Anybody?
Roughly, how many of us are here?
Uh, I think
19 as presents, ma'am. 19 doctors.
19 as participants. Okay, okay. That's a number. Maybe when you start speaking, you can introduce yourself and just tell me so that, I'll just know what kind of work you are doing and the query. Okay. As Sir said, probably you must have gone through the modules on depression, anxiety, and delirium, right? Can someone please answer? You all have been given, right? You all have been given the modules.
yes, thank you.
Yes, okay, okay.
So I know there are at least some unexpected in this group. So they are familiar with delirium in the setting. So if you have had any problems in managing patients in ICU with delirium, anybody?
Okay, okay. Someone has said didn't get time to go through the module. Okay. So
Do you have any doubts regarding anxiety, depression, and delirium?
okay. So I guess maybe I'll start talking on the subject and then your doubts you can clarify. What if you see a patient who's admitted in the palliative care? I guess at least some of you are working in palliative care. And so a patient receiving palliative treatment has come under your care and she has reported with, she's say roughly around 60, 70 years old, say 70 years old. She's a retired teacher and she has no past history of mental illness. Okay. There is no past history of psychiatric illness, but suddenly this patient started behaving very abnormally. She was sort of talking very irrelevantly, confused. She appeared very confused. She was saying she was in school and she started taking classes for the students. And it was kind of very difficult to manage her in the night. So this patient is on treatment for malignancy, CA breast, advanced stage. Of course, receiving palliative care and diabetic, hypertensive. There is history suggestive of renal failure. Her creatinine levels are high and she's admitted under your care. With no past history suggestive of psychiatric illness or even family history, you were not able to gather. But this patient is behaving very abnormally. To you, she's appearing very confused. If you test her orientation, maybe she's disoriented. And also, when talking irrelevantly means whatever questions you're asking, the patient is sort of giving answers not to the question. She's speaking something else. Like she was at the night, she was busy taking classes for the school children. So what sort of a disorder is that? Have you all come across such cases? This is delirium. Someone has answered. Very good. Delirium. Yes, ma'am. Nilaksi, you want to? There's no question on that. Maybe you can unmute your audio and ask. Sundowning associated with delirium. Very good. I believe that's a psychiatrist or somebody from the mental health. I mean, it has to be a psychiatrist. Right. Okay, this is delirium. You're right. Most of you have answered it as delirium. Any other take? Any other? Or it's all of you agree on that diagnosis of delirium? So what are the catching points in this case? CKD, so need to rule out uremic encephalopathy. Okay. Acute onset, very good. Acute onset. Then acute onset, right? That's true. Acute onset. Acute onset of confusional state with no past history, right? There is no past history of psychiatric illness. And there are enough pointers towards a medical possibility, like someone has suggested uremic encephalopathy. So those are the causes for delirium actually. Why is this patient delirious? So if we try and look at the causes, you can see that all these could contribute to the delirium. So delirium is an acute confusional state where the patient becomes disoriented. They will probably not understand what you are asking them and they'll talk very irrelevantly. Because of their confusion, they may, there is someone has said it is sundowning. As the sun goes down, their symptoms worsen. So the delirious patient, they become quite agitated. So when you go for night duty, you see the patient very, disturbed. They may pull out IV lines. They may pull out, all sorts of tubes and, try to run out from the ward or the ICU. Very common in ICU settings. So they may try to run out from the ICU. They may start feeling that, the nurse who's coming to administer some medicines, they may have these perceptual disturbances and even psychotic symptoms like perceptual disturbances and delusions also. So they may feel that these people are coming to harm them. So if you go as a big crowd to, take rounds for this delirious patient, he's bound to become very agitated and, confused. So this is a clinical picture actually. And what are the, causes that you can think of in this particular patient? Why is this delirium due? Or usually we say this is delirium due to a general medical condition. That's how we put it. Okay. So delirium due to general medical condition and the medical condition in this case, someone has said metabolic, Anju has said it is metabolic drug induced. Then, okay, someone has said uremic encephalopathy. We used to call, when admitted in, that is actually a misnomer when we call them ICU psychosis. Post-ictal brain metastasis, very good. So all these are possibilities. So all these are, am I just going along with the psychiatrists that the other doctors in the group are, not trying to follow, not able to follow what I'm saying? Can someone else, other than a psychiatrist answer? Anju is an oncologist. Very good. I really appreciate your knowledge on mental health. Someone else? Oh, is it okay? Shall I continue this way?
Yeah.
Namrata? Can you follow? Following. Okay, very good. Yes, ma'am. Okay, fine. In case you're not able to follow, just put in a query, okay? So that I can explain, because I'm not seeing your faces. I'm not getting any feedback. I'll not understand whether you're with me or I'll just be talking, okay. Okay. So we are all together. I'm an anesthetist. Okay. Are you able to follow what I'm saying, Chandrika ma'am? Yes. Oh, okay. Very good. Very good. Fine. Okay. So this delirium, we were talking of about this patient, delirium, and we thought of causes like metabolic. There could be an infection. Infection is a very common cause, especially in a vulnerable brain. Say if she has a brain mets, and brain mets by itself can produce delirium. Other than that, sometimes if there are brain mets, as someone has suggested, a patient may have seizures, and post-ictally, these patients may develop this confusional state called delirium. Okay, so that is a possibility. Infections by itself is a very common cause, especially in a vulnerable brain, like an elderly brain. When they develop, even say in females, it could be a UTI, urinary tract infection. Or in males, it could be a pneumonia. If it is unidentified, we will be doing all, brain imaging. We'll be doing all sorts of tests to find out why this patient is behaving this way. We may overlook this UTI. So such common things you have to keep in mind. Whether there's a possibility of an infection, whether there's a possibility of a metabolic case, like the case that we discussed, there's high chance that it is due to metabolic reasons, like uremia, you said. Renal failure is a common condition. All organ failure, there could be possibility of delirium. Renal, especially because the metabolic parameters go up and down. So she's a diabetic. Maybe her diabetes was uncontrolled. So hyperglycemia, diabetic ketoacidosis, patients may develop delirium. So metabolic causes, infections, trauma to the head. Sometimes patients may have a fall, and at that time they didn't have anything suggestive of say brain insult. But later these patients may develop subdural hematoma, and they may appear very confused. So such kind of clinical situations are possible. So we have to keep all these are all given in your module. Likely causes of delirium. And we have to, from the history and your clinical examination, you have to think of the possible investigations, less invasive ones first. And like if you suspect, say meningitis or something, maybe an LP or something, only if it is indicated. So the investigations will basically depend on what sort of history and examination findings that you get in the case. Now, how are you going to manage this? This is obviously a very common clinical condition. Actually, this patient can present in, they can have different clinical presentation in the sense that sometimes the patient may be hyperactive. There is hyperactive delirium. Sometimes, usually, as the patient progress, differentiate between hyperactive and hypoactive. Right. So sometimes the patients may go into hypoactive state. So you'll think that, this your patient has improved. Thinking that, the activity, the restlessness has come down, so the patient is better. But actually this hypoactive state is more dangerous. That is more morbid. Mortality is more in that. Now, some cases, at least there could be substance withdrawal also. Substance withdrawal and the co-medication. Suppose the patient is already on anticholinergic drug. Acetylcholine actually, keeps levels of consciousness and alertness intact. So when there are anticholinergic drugs being administered for other purpose, patients may go into delirium. So always take a careful history always look at the clinical examination findings, see the drug chart, see what are the possibilities, and then we have to think of managing this. Okay. Obviously, because we are saying, say, delirium due to metabolic encephalopathy. Now, obviously, there's a cause, and you have to treat the cause. So the cornerstone of managing a delirious patient is that you have to identify the cause and manage the cause. There is no point in pushing haloperidol or antipsychotics to this patient. It is used for symptomatic management, only for symptomatic management. You have to identify the cause and you have to manage the cause. And during management, there is actually something called delirium nursing as such. Because, non-pharmacological as well as pharmacological management. Non-pharmacological management is very, very important in this patient. Because, as I said, if we go in a big group, the whole unit goes to take rounds for a delirious patient. The patient may feel that, all these people are coming to, attack me. So they may try to run out of the ward. They may try to jump out of the window. So you have to keep in mind you are dealing with a confused brain, with a delirious, disoriented brain. So when you go try to, it is always better that that minimum number of people go to this patient. It could be the nurse or it could be the doctor. You go. When you talk to that patient, see that you give only simple instructions. Simple instructions clearly. Clearly, you can't, please avoid all these multi-stage commands and all. They'll not be able to follow. So what exactly do you want this patient to want this patient to do? Just get up or sit up. Angana clear it. Just give brief commands, give clear commands. Always keep in mind that this person is totally confused. So don't make him more distressed. Okay. And see that injuries are avoided. Because as we said, because of the perceptual abnormalities, these people may, try to harm others and try to harm themselves also. Because they become very fearful, especially at night. So care must be taken so that their safety is maintained, the safety of the patient as well as other patients lying, on the other beds. So it's not very common for them to harm others, but because of these delusions and hallucinations, symptoms may vary. You have to keep in mind such a possibility also. Avoid bed sores, avoid, maintain fluid and electrolyte balance. Avoid possibilities of getting infected. So all these things you have to keep in mind. So putting all these non-pharmacological management together, we call it delirium nursing. And try to reorient this patient. Minimize the use of IV lines and, all unnecessary things you can take away from the orders. But essential things you can, you can keep monitoring the patient as well as, if that patient is in the ICU and if there's a possibility that he can be managed in the ward or in the room, it is better to shift him early. So someone has said early migration. So that also you have to keep in mind. So I guess I have missed some of these chats. Visual and hearing aids. Yes, visual and hearing aids, because sensory deprivation always worsens delirium. So if the person usually use spectacles, it's better to give them their specs, or hearing aids, it's better to do that. Okay. In a patient on palliative care with hyperactive delirium when he is capable of harming himself, I couldn't read the rest. Can the person unmute the mic and ask?
So I will read in a patient on palliative care with hyperactive delirium. When he is capable of harming himself, creating damage to devices, is
So
there
can't
a
hear,
role
sir.
for
One second. Let me see the chat. Or creating damage to devices, is there a role for physical restraints till pharmacological agents can work? Is there a proper way of doing it? It's best to avoid physical restraints in this patient. You can actually keep him in a, not in a less crowded area, not a very secluded area, but a less crowded area. See that the lights are, at least dimmed during the night, so that this day-night orientation is, whatever possibility there is to maintain that day-night orientation, you do that. They say, try to give a, big clock with big numbers, so that when you speak, that you can, when you say now it's 6:30, they can look at the clock and they can be convinced. So that is called reorientation. Try to tell them the time, try to tell them what day of the week that is. Okay, physical restraints, because they are already confused. They are feeling that they are they are going to be harmed, or not all patients, but some of them. So at that time, if you try to physically restrain them, that is going to be a very difficult time. Yeah, more than that, it is best to reassure. Use low dose of antipsychotics. It could be haloperidol, it could be risperidone, it could be some okay. So what is this? Some transcript has come up. Okay. So physical restraints, you can use chemical restraints like antipsychotics. Antipsychotics, very low doses. Possible minimum dose you have to use. Okay. If it is alcohol withdrawal or something, you can think of lorazepam, provided there is no respiratory compromise. Okay. Sleep hygiene, cognitive stimulation. Cognitive stimulation more in terms of reorienting the patient in terms of time and day and date and all. Okay. So unless and until you identify the cause and address the cause, your patient will remain delirious, and that is not good for him. So it is best to prevent onset of a delirium. Like an elderly person getting admitted in ICU with all these comorbid risk factors, see that the fluid electrolyte balance is maintained, see that the day-night orientation is managed, is taken care of. So all these things, possibilities of infection. If there is an infection, you can, start the treatment early. Avoid unnecessary investigations, avoid unnecessary tubes. So all this will help in preventing possibility of a delirium. And in alcohol withdrawal and all, you anticipate and you start benzodiazepines early enough so that they don't go into a delirium tremens. Okay. So this is basically delirium. Now you can ask your doubts on the topic. Dr. Karthik, I am seeing your name on the... You want to ask something? Were you able to listen to the whole thing? Someone else? Pharmacological treatment of hypoactive delirium. Hypoactive delirium, again, usually it will be hyponatremia, hypokalemia. Metabolic causes are very common. So again, it is management of those electrolyte imbalances and other cause that has precipitated this hyperactive delirium. There is, because the patient is very calm, peaceful, they actually don't need an antipsychotic. Antipsychotic is used only for symptomatic management in least possible dose. And physical restraints are best avoided because the patient has many other things to be taken care of. Even if they become restless, just keep their, safety margins, that's enough. Don't put them near don't put them on the 8th floor with the window just near their bed, to avoid such things. Keep them where, supervision is possible for at least a staff where, they are available nearby. Give their sensory aids, visual, hearing aids, all those things. Difference between hyperactive delirium and depression. Hello? Am I clear?
Yeah, yes.
Hello?
Please go ahead.
Dr. Anju, you are clear. You can go ahead, ma'am.
Okay, fine. So difference between hyperactive and delirium and depression. Can you make an attempt? Delirium, now you all know. So how to identify depression? Depression is, depression is different from in matters like, say your patient will be totally oriented. Your patient will not be confused. Your patient will have a cluster of other symptoms called depressive symptoms. Now, what are the message says we have to restart. Sunil. Hello.
Which message, ma'am?
You need
Okay, that will happen automatically. Will I have to rejoin?
No, I guess, ma'am. You can continue. We will see, ma'am.
Okay. Okay, so there are answers here on the chat. Symptoms of depression should last more than 2 weeks. Okay, that's what the ICD-10 or the DSM-5 says. Worthlessness, hopelessness, anhedonia, feelings of guilt, suicidal thoughts. Okay, all of these are symptoms of depression, right? You're absolutely right in all of them. Sleeplessness. Okay, so these are so the patient is different in the sense that the hyperactive delirium patient, the patient will be confused, patient will be disoriented, patient will be talking irrelevantly, and there will be other causes suggestive of a likely medical cause for delirium. Whereas in a patient with again a question on delirium. I'll take that first and come back to depression. Which are the most common causes of delirium in palliative home care settings? It's same set of things, because hyponatremia or can occur at home also. Diabetic ketoacidosis can occur at home also. So these metabolic things are very common. Infections are very common. Patient is on Foley's catheter. You are visiting for a catheter change. Patient, may be diabetic. There may not be any fever, but patient is confused and delirious. You have just do a simple, ask them to do a urinary routine examination and get back to you. So the causes remain the same, whether it is home care or hospital care, except for probably the ICU setting where there is an added sensory deprivation which is causing delirium. Suppose cause is progressing, like brain mets, which is not correctable, how to manage delirium that persists? It will depend on symptomatic management only, unless and until we can think of, a possible, surgical intervention for the meds, which rarely happens. So, you know, just take the patient through the delirium, through adequate nursing care. And whatever possible palliative care that you can offer. Can
I
you
would
please?
like to comment here.
Sure.
So, delirium is very common in patients with who is receiving palliative care, and there are many things which can precipitate delirium. But there are a very common few factors which can precipitate delirium, and you can remember it by the mnemonic CHIMBOP. C for constipation. So constipation is one of the most important symptom that can occur in palliative care patients. Then hypovolemia, hypoglycemia, hyponatremia, hypercalcemia, I for infections, M for medications. So any medications with anticholinergic properties. So we use a lot of tricyclic antidepressants, opioids, maybe hyosin butyl bromide. So many medications are there. Then bladder or bowel outlet obstruction. So many patients they can have urinary retention, which can actually precipitate delirium. Then reduced oxygen saturation and unrelieved pain, P for unrelieved pain. So these are not the only factors, but I'm telling these are the most common factors which nobody will look for. Because as Dr. Anju told, there will be many investigations which might have done, but they might have overlooked a constipation or a urinary retention.
Yeah, so that very commonly happens.
Yeah.
So please continue.
And there are famous stories regarding constipation and delirium, which even we have faced when we were working in tertiary care hospitals, where there are a lot of specialties, and so constipation was one of the most common cause for which is usually missed, which precipitates delirium. And regarding the treatment, previously everybody was using antipsychotics in addition to correct the correctables. But nowadays, more and more evidence are coming, and which says we should be concentrating more on non-pharmacological management and correct the correctable factors. Antipsychotics are indicated only if the patient is agitated, or if they produce harm to themselves or harm to others, or if they have hallucinations or delusions. Otherwise, we need not use antipsychotics. So there is a common tendency to use antipsychotics if the patient is diagnosed with delirium. It should not be done because antipsychotic itself has many side effects. Yeah,
okay.
that's all.
Thank you, sir. Thank you. There is another question which probably you may be able to explain better. Can you please opine regarding opioid dose reduction and opioid rotation in a person with delirium?
Yeah. As all of you know, one of the toxic effects of opioids is delirium. So the other toxic effects include delirium, myoclonus, and undue drowsiness. So if the patient has frank delirium, then you have to actually stop or skip the opioid dose for maybe 1 or 2 doses need to be skipped, And when the patient is alert, then you have to reduce the dose of opioid. Or otherwise, then you can also use opioid rotation. But in India, it is there are not much opioids to rotate. If you are using morphine and you have only, I don't know how many of you have other opioids. We have only fentanyl patch, methadone, and methadone is only used in only in some institutions in India, maybe a handful of institutions. So you do not have any other choice other than morphine. So you have to skip 1 or 2 doses, then restart with a reduced dose.
Okay, sir. Thank you. Thank you. Okay. Okay, I think I will share the case of a patient who actually I took care of him through the last days. This patient actually came to me following a drug overdosage. And the drug overdosage was actually, he was trying to, he was trying actually to kill himself. Now, I talked with this patient, and he said, he was having lung cancer. So, malignancy, he was referred to palliative care, and that made him think that, it is over. And he was having quite distressing symptoms also. He was having difficulty in breathing. Night, he was not unable to sleep. And there were, bone pains. So there were kind of, symptomatically he was distressed, and then he felt, it's all over for him. He was around, say, 50 years. He was an earning member in the family. He was the only earning member in the family. He had 2 kids to be taken care of. And, his wife was not working. So, all these situations made him in a very delicate position. And he was feeling very helpless. He was thinking that there is no hope for him, because even the treating doctors, they said, it's kind of difficult. You don't have to, be in the, be receiving any chemo or, radiation. And, the question of curative care was out of question. That's what was conveyed to the patient. And following that, actually, he developed all these symptoms, and his family thought it's all part of the illness. He's having, of course, anyone diagnosed with a major, terminal illness and showing symptoms of that, unable to take care of the family. So he thought, why, it was so distressing. Why go through this pain? Let me end it all for once. The family anyway has to, carry on. So he thought, at least, if he is out, these financial things that come upon because of his treatment, that will be spared. I mean, but the family may be spared of that. So that's why he attempted a drug overdosage, and he was brought to me. Because he was admitted in medicine ward, and then before he was discharged, he was sent to us. Okay. So what do you think here the issue is? How would you like to put it? Is there a problem? Is it a hyperactive delirium? Yes or no, and why? Just try answering. Anju, right. Depression, you're right. Any other? Prarthana has said it is anxiety and depression. Any other? Anyone feels, I mean, someone had asked whether it is, how will you differentiate hyperactive delirium? I want that person to answer, please. Do you think this is hyperactive delirium? No. These two clinical conditions, probably you ask for the differentiating factors because both of them may present with psychomotor retardation. Patient may be very calm, quiet, and the psychomotor activity levels will be very less. So, but then in depression, that is a different group of symptoms. Like in this patient who has presented to us now, and possibility is that of depression, right? Now, do you all feel it is part of the illness? That anyone who goes through this should be depressed before they really make an exit? Yes, okay. No. Total pain. Normal grief is okay. See, I mean, the situation that our patient is in is definitely distressing. It will be distressing to anybody. But more than that, before he is called for, he's trying to make an exit. Just imagine the condition of the family members who are desperately.
Dr. Sunil, I think we lost Dr. Anju.
Yeah, we can wait for her.
Okay, sir.
And I see there is another question on, suppose the cause is progressing brain metastasis, which is not correctable. How to manage delirium that persists? So this can happen in some patients, and you have to actually communicate with the caregivers. One thing is that sometimes some patients might need steroids like dexamethasone for rest of their life, and that can actually reduce the peritumor edema and can help the patient up to an extent, but um, you have to use it in a proper way, because steroids, if you use it at night, and it can produce delirium, precipitate delirium. So probably it needs to be given in the morning time, so that it will be, that the cortisol secretion, it occurs in the morning hours. So better to give in the morning hours. And mannitol can be given, but mannitol cannot be continued, because if you continue mannitol, the action would be opposite. Instead of reducing the peritumor edema, it can increase the peritumor edema. So it is not advisable to give mannitol more than 3 to 5 days. And if the patient is agitated, some patients might require, palliative radiotherapy is definitely an option. And if the patient is still agitated, maybe you have to use small doses of antipsychotics, maybe even haloperidol, quetiapine, risperidone, olanzapine, any of those. And the haloperidol has maximum side effects, so some people may advise olanzapine or quetiapine.
Okay.
And Dr. Anju has joined back.
Yes. John from the mobile. Something happened to the computer. Okay. Okay. So where were we? We were talking about that case, right? So,
Yeah.
okay. So it is not inevitable that these patients should make. I mean, these patients have to go through depression. Hmm? Depression is another pathological state, like we would call. I mean, depression. The word has become so common that we think that it is part of day-to-day life. Hmm? Depression is a very common clinical condition, but it is not an inevitable reaction to a terminal illness. Hmm? So, and it is not inevitable, and depression is treatable also. Hmm? We have antidepressants which I mean, what are we trying to do in palliative care? We are trying to improve the quality of life of the patient, right? And the family members. So, if we want to improve the quality of life of the person and the family members,
Dr. Anju?
hello.
Yes, ma'am, we can hear you now.
Okay. Weren't you? I mean, did you all follow what I said?
We heard till the quality of life you mentioned.
Yeah. Okay. So we are trying to improve the quality of life, right? And here in this particular case, we have this patient where the family members are desperately trying to help him, trying to find all resources to get him treated, or so that I mean, at least those days that he's with the family, they wanted him to be, at least content. Hmm? But the patient resorting to a suicidal attempt means the family is feeling very betrayed. Hmm? The family members feel that we want him to be with us at least for 1 or 2 days more. Hmm? That's a condition that they were in. Hmm? So now he feels that he's a burden and he's trying to end his life. Hmm? So that is totally very distressing to the family members also. So you have to identify and treat depression to avoid such clinical situation. You have to think of the possibility of a depression. It's not like it is an inevitable part of a terminal illness. Hmm? And it is not incurable also. Hmm? Now, if a patient is depressed, they may refuse to take other sorts of treatment. They may say, why waste time, money on, getting palliative care? Why waste money on going to meet the doctor? Hmm? Why waste money on? So they will put all these excuses. Hmm? So if you want your patient to be compliant with what you are trying to say, so that he gets better care, hmm, it is important to identify and treat depression. Okay. So these are, and studies have also shown that depression actually influences immunity. Hmm? So that way also, it is better to treat this clinical condition. Hmm? Commonly what happens is we think all of us feel depressed, all of us feel sad. We try to make it try to normalize the situation, saying that this is sadness, this is just part of the part of the illness. Hmm? But when we normalize, say if we used to call this clinical syndrome as, say, syndrome Z, or syndrome some K or something, we could identify totally, I mean, this clinical condition where these patients need help, rather than just saying, it is part of the illness, or, it is quite normal for this patient to have this sadness and, depression. Hmm? Because of the word that we use very commonly, hmm, that we commonly use in our day-to-day life. I hope you understand what I am trying to say. Uh, so it is very, very important to identify this clinical syndrome of depression. It is given in detail in the module. You can ask any doubts related to that.
I think you can talk about medications that can be used to treat delirium if there is severe depression.
Depression. Okay. It is all given in the module. We usually commonly use SSRIs, selective serotonin reuptake inhibitors. All the antidepressants have nearly the same efficacy, but side effect profile is a bit better for this SSRI group, except for in the patients that we kind of handle in palliative care. They may go in for a possible hyponatremia. So that you have to keep in mind. If there are symptoms suggestive of that, you have to see the sodium levels. Other than that, drug interaction is minimum. Other side effects are minimum. Anticholinergic effects are minimum. So we commonly prescribe escitalopram. Say you could start at a dose of 5 milligram and optimized to 10 milligram. Most of the patients, because they are very frail and uh, they may need only 10 milligram. In SSRIs, they have a therapeutic window phenomenon, which higher doses other than more going beyond 10 milligram actually doesn't add to the clinical effects. And it will increase the side effects. So at least in this patient population of palliative patients, you can safely go to levels of 10 milligram and stop there. So other molecules, amitriptyline is a time-tested molecule which has a role in pain control also. So tricyclic antidepressant, they have they have an anticholinergic effect which limits the use. There are drug interactions, possibility TCA overdosage is more dangerous than escitalopram overdosage. So all these things kept in mind. More than that, or supportive kind of we call it supportive psychotherapy, but at least those elements of giving your patient reassuring them in the way that you are also part of the journey, that you are also there, and patiently listening to them. They may have many worries. Like this patient, he was in tears when he was trying to explain all this. But then at the end of the interview, he was willing to take medicines. He became better. And of course, survived for a period of, say, I think it was 6 months or 8 months. After that, he passed away. But at least the family felt that they could take care of him. That those last days, at least he was trying to relate to them better, and they were all part of the process. So that counts for such a patient. And so it is important. All these non-pharmacological thing, you have a good rapport with your patient. You have otherwise also in palliative care, it is indicated to give them or empathetic, warm presence, which they may feel very reassuring. Okay. So that is about depression. Any questions, queries?
Can you talk something on anxiety?
Anxiety, I think the case that she had sent is anxiety.
Okay.
So probably we'll go to that case and.
Yeah. Okay. I think now we can go to the patient story. Radhalakshmi?
Yes, sir. Which one to start with, sir?
You had sent only one case to me.
The one which sent to Dr. Anju.
Okay.
Actually, I just glanced through it. You can present it actually. Somebody can present it.
Yeah. Good evening, all. Am I audible?
Yeah.
Yes, sir.
Yes.
Myself, Dr. Jones James. I am working as psychiatrist in Indira Gandhi Hospital, Kavaratti. So I will present this case with my video off due to the fluctuating network connection and heavy rains. So this patient is aged 23 years. He is a male, diagnosed with left parietal lobe astrocytoma grade 2 to 3, status post left parietal craniotomy and gross total excision, status post radiotherapy with adjuvant chemotherapy, undergoing monthly cycle of chemotherapy 5 days per month. Next slide, please. Presenting complaints are worries regarding the illness, treatment, and financial constraints. Also, fear of recurrence, side effects, pain, death, anger towards self and others, and sleeplessness. Next slide, please. History of present illness. There was history of sensory seizures followed by one episode of GTCS around 7 months back. CT brain was done after neurologist consultation. It was suggestive of left parietal lesion and MRI was suggested for that. MRI brain plain and contrast showed left parietal lobe mass lesion suggestive of intermediate to high grade glioma. Left parietal craniotomy and gross total excision of the mass was done 7 months back. Intraoperative finding was suggestive of grade 3 lesion. However, HPR showed diffuse astrocytoma, IDH mutant, WHO grade 2. Radiotherapy with adjuvant chemotherapy was done around 4 months back and currently undergoing monthly cycles of chemotherapy, tablet temozolomide orally 5 days per month. Past history of social use and of alcohol and tobacco is there. Next slide, please. On examination, there was no pallor icterus, clubbing cyanosis, lymphadenopathy, and edema. Vitals are stable, moderately built. Tenderness was present over scalp over the craniotomy site. On CNS examination, there was slight reduction in the sensory perception over right upper limb and right lower limb. Other systems were within normal limits. Next one. Treatment and significant investigation. Left parietal craniotomy and the gross total excision was done 7 months back. Radiotherapy with adjuvant chemotherapy was done 4 months back. And IMRT was done in 30 fractions for 6 weeks. That is 5 days per week. And along with the tablet, temozolomide, 160 mg per day was given for 6 weeks. Currently undergoing monthly cycles of chemotherapy with the tablet, temozolomide 300 mg per oral, 5 days per month for 6 months. Post-surgery MRI brain showed craniotomy defects in left parietal bone with the post-resection gliotic changes and parenchymal defect. Other investigations, blood investigations were within normal limits. Next slide. Regarding the psychosocial aspects, he is a degree student. He belongs to middle socioeconomic status family. He is single. His father is a farmer and mother is a homemaker. And his younger brother is a nurse. And there is financial constraints in the family and they were supported by other relatives. He was aware of the diagnosis, treatment, and the prognosis was explained to him by the treatment team. Next slide, please. The medications, as explained, he is currently undergoing monthly cycles of chemotherapy with the tablet temozolomide, 300 milligram orally, once daily for 5 days every month for 6 months. Along with that, pantoprazole 40 mg in the morning and ondansetron 8 mg per oral was given half an hour before temozolomide. Next slide, please. The main concern is psychological reaction to the illness and treatment, anticipating recurrence, side effects, pain, death. Financial constraints is there in the family. He is experiencing spiritual distress also, and psychosocial support is also a concern. Next slide, please. Summarizing this, 23-year-old male diagnosed with left parietal lobe astrocytoma grade 2 to 3, status post left parietal craniotomy and gross total excision, status post radiotherapy with adjuvant chemotherapy and currently undergoing monthly cycle of chemotherapy 5 days per month. Persons with psychological reactions to disease and treatment, fear of recurrence, side effects, pain, fear of death, and financial constraints in the family and spiritual distress. Next slide, please. The discussion points are psychosocial assessment and addressing psychological reactions to the illness and his fears, enhance coping strategies, and communication with the patient and family, management of physical symptoms such as pain, psychological, social, and spiritual support, and being available to them, involving the community in the treatment, and further future plans for him and the family. Thank you all for listening.
Thanks, Dr. Johnsy.
Thanks.
I guess we'll take it to, okay, we'll take it up, psychosocial assessment. So what exactly here, actually, one thing that we have to keep in mind is in this patient, further evaluation for possibility of depression should also be there, because depression can actually be accompanied by anxiety. So anxious distress is very common in depressive patients. So whether there's an underlying depressive disorder, we have to see. Okay.
Yes, ma'am.
That is there. Other than that, there are a couple of social support issues, spiritual support, you said, psychological support. Now, when we talk about distress, actually, in a person receiving palliative care, we have to think of all these elements of distress. And actually, there's something called a distress thermometer, which actually looks into, it's a visual analog scale, which looks into physical distress, psychological distress, spiritual distress, all these, even environmental material things which can be provided for. So, say someone needs a wheelchair and they don't have a wheelchair, and the family finds it difficult to put him on a chair and carry him on a chair. So in such cases, giving these supplements, or giving these things what they physically need is also very important part of the palliative care process. Okay. Now, in this patient, what other psychosocial assessment can we think of? One is possibility of depression, possibility of anxiety disorders as such, right? Can use GAD-7, you can use hospital anxiety depression rating scale. If you want to rate and see how, it's all given in the module actually. You can, if you want to rate and see how much distressing the symptoms are to the patient. Okay.
Yes, ma'am.
Now, addressing these fears, of course, talking with the patient, listening to them. In all these psychological issues, it is very, very important to listen to the patient. Now, just listening to them makes a huge difference. Sometimes we are very busy, like when we go for home care, probably we have to cover 5-6 houses, and you need to travel a bit more, and you need time for that, and so you may not be able to spend so much of quality time with a single person. So that is a major limitation. But it is very, very important that the time that you are able to allot to a person, you sit and let them do the talking, and actively listen to what they say. When I say actively listen, show interest in the person and show that you are actively listening to them. Sometimes you can ask them a question and you can be busy browsing the social media. So such things should be avoided, especially in palliative care. So that is how we communicate, that is how we really show that we care, that we are there. And of course, try and find out what kind of disorder they have. End of life, all these concerns may be there, the spiritual concerns. They want to reconcile with somebody, that close family member whom they have not talked for years. Suddenly they feel that that person wants to reconcile with them. Or sometimes they want to do those religious rituals, preparing them for the inevitable. So all those things, if possible, should be could be addressed. Okay. and enhanced coping strategies. It depends. For your patient, yes, definitely, because he's a degree student around 23 years. And sometimes, if he really makes through it and, keeping him hopeful and, having some meaning for at least, for whatever situation of the life he is, having some meaning for his life. Mm. So, staying connected with his friends, probably at that age, friends are very important. So, staying connected with them, staying connected with family, how can the family best, support this person? Try and find out that. Hmm? So, psychosocial formulation will actually include all these aspects. And definitely, as you said, being available for them when they have their queries, when they have their difficulties, and involving the family also in the treatment process. Anxiety symptoms, if you need to control acute anxiety relief, you would know we use benzodiazepines, right? But we have to see whether the other physical parameters, especially the respiratory, the patient is not in respiratory depression or, such things are not there. Other than that, benzodiazepines gives acute anxiety relief, very fast anxiety relief. And if there is an element of depression, they need to be put on antidepressant also. Most of the something like generalized anxiety, they are anxious for all possible reasons. Everyday things, they're very anxious. Such kind of persons, they may need this SSRI, or you could use molecules like mirtazapine, venlafaxine. These are all antidepressant which has got anxiolytic effects also. So you can possibly think of such molecules. And community participation, of course, if there are, chaplains or religious things has to be done, and there are, the role of NGOs is very big in this, mobilizing all this and, getting things done. Future plans, what would you want to say, Dr. Johnsy?
Ma'am, regarding his education continuation, then
Yeah, definitely.
family life and all.
Definitely, because one thing is, before we start talking to the patient about the whole thing, we need to discuss with the oncologist, and try and find out what these really mean. When we say grade 2 or grade 3 parietal, glioma, and what sort of, what is the kind of prognosis that we can safely communicate to this patient? When I say reassure, it is not like, you're going to say that, you're not going to die, or it's all going to be okay. We definitely, we are all, as doctors, we are all trained not to, give them all false reassurances. Better than that is, especially for a degree student, better than that, it's to put these facts. You will have classes on communication, on how to communicate bad news and all. You will have sessions, but definitely those elements need to keep in mind. You have to keep in mind when you communicate with that person. But one thing is, even if you know the prognosis is poor, in your first visit, maybe maybe he's not in a position to take, to take all these in. So maybe you can do it in parts. Maybe you can ask him, what do you think? What has the doctor already communicated to you? And with the knowledge that you have gathered from the oncologist, or you could do, you could refer and you could talk with the oncologist and try and find out how exactly his prognosis is going to be, and give them a realistic picture, don't give them undue expectations, but but at the same time, don't say that it's all over and better way to die. Avoid such blunt statements and false reassurances. It is always important that these people, I mean, these persons, they will also know, but that someone is there to share their distress, to be part of the journey. That is very, very, very important. And maybe Dr. Anju can talk on this particular case. Can you throw some light on the prognosis that you expect in this person? Dr. Anju? You said as she left. Can't hear you. I can't hear you. Hello?
Hello, ma'am.
Yes.
No. Yeah, there was one oncologist, Dr. Anju.
Yeah. Dr. Anju Anna?
No, she's not audible. I can't hear. Kekava, Sunil sir, can you hear?
No. She's not audible. I don't know whether even I
Maybe
can't
she's
see.
occupied. Okay. Okay. So definitely, if she was available, we could get an idea. So that is important, and addressing these financial issues, social issues, how we can mobilize support for them, resources for them. It's all part of the process. And communicating and and I think it's also important, apart from this case, it's also important to take care of yourselves also. This is a very, when you are exclusively working in palliative care, it actually takes a high toll on you also. Seeing physical, emotional distress every now and then. So I would advise that have some methods to take care of ourselves, some time for ourselves, some time for our family. Some things that we would like to do, like your hobbies. Taking care of your physical health, emotional health, all these are also important. I think basically this is what I wanted to communicate. Now, any queries on that, you can ask. Survival is 2 to 3 years for grade 3 astrocytoma. Thank you.
Anybody else want to comment on this patient or anything else on which we had discussion?
Sunil sir, would you like to add something?
No, actually, this patient, she has brought up many psychosocial and spiritual issues for this patient. So when we look at the patient as a whole, we should, in addition to the physical symptom relief, we should also take care of the psychological, social, financial, and spiritual distress of the patient. Not only patient, as well as family. Here, I don't know who all are there in the family. And we also need to understand what the family is going through. So that's very, very important. Because everybody will be concentrating towards the patient only, and nobody may not be there to listen to the problems of the family, his parents, uh, how they are coping. That's also an important questions to ask. Because 23-year-old son and he's having this incurable illness. So probably they are going through a very stressful situation in the life. So
Very true.
I think it need to be taken into account, and uh, if he has any siblings, then that's also very important. The situation becomes worse when the children are younger in the pediatric age group, maybe a 10-year-old child. Then they may not be knowing anything about the what is happening in the family, and all the care will be diverted to the patient, and they may think that, okay, my father and mother is deserting me. So all those are questions. Yeah, I
Yeah,
can
there's
see.
a query
Yeah.
that asks whether it is normal grief or anxiety or depression. Okay. That is, I mean, the primary elements of making a psychiatric diagnosis, because these are all human emotions. Like, I'm audible, right? Hello?
Yeah, you are audible, but there is background voice. I don't know whether it is from your side.
I request Dr.
Okay.
Sanish to stay muted. Ma'am, you can continue.
Okay, thank you. So when we basically make a psychiatric diagnosis, what are the things that we look for? When we, because these are all normal human, emotions, that we speak of: sadness, anxiety. So you can also, anybody can become anxious. Anybody can become sad, but these are usually transient phenomenon. You don't always stay sad. You don't always stay anxious. So in particular situation, just before you get into an exam hall, maybe you're getting a bit of palpitation, or maybe you're feeling very nervous when you're about to enter into your orals viva room. So there could be some anxiety symptoms, but it becomes a disorder when the person finds it difficult to even go for the exam. Hmm? Like thinking of how he is going to perform, or so the dysfunction is very obvious. Hmm? The person is so depressed that he's thinking of contemplating of killing himself if he's carrying out acts to end his life. Hmm? So then it becomes a problem. So one thing is the cluster of symptoms as as stated by the diagnostic criteria. And who gives the criteria? Well-known, WHO gives the ICD-10. Now currently it's ICD-11, International Classification of Disease and Health-Related Behaviors. So ICD is for all illnesses. For infections, you have nervous system disorders, you have, and fifth chapter deals with mental and behavioral disorders. Then you have the very popular American Psychiatric Association DSM-5 criteria, Diagnostic and Statistical Manual for Mental Illness. That is exclusively for psychiatric disorder. Current edition is fifth edition, DSM-5. So they will say that, when you say you can't call something as just depression. You have to call it major depressive disorder according to DSM-5. So when there is major depressive disorder, so these are the cluster of symptoms that is going to be seen in this patient. For example, if it is a major depressive disorder, it will be something like there is persistent sad state, or some patients may be irritable. Then there is lack of interest in previously pleasurable activities, like we call it anhedonia. The people used to enjoy music, now they don't find any enjoyment in music. Hmm? So these are and there is excessive fatigue. Always feeling very, feeling very tired. They are unable to concentrate in what they are doing. they lose interest in that, and they have these feelings that they feel very guilty, they feel that they are burden to others, they feel very hopeless, they feel helpless, they feel worthless, mm, and they think that there is no point in continuing with their life. So suicidal ideas or suicidal gestures, attempts are there. mm. So the criteria says at least one of the first two symptoms and at least five of the other symptoms. So that's how we make psychiatric disorders. And any of these symptom cluster, they should occur for a set period. Like someone said, major depressive disorder or a depressive episode should last for 2 weeks. But again, that is a clinician's judgment. You can make a diagnosis of a major depressive disorder when there is 1 week of symptoms itself. Don't have to wait till 2 weeks, because you can provisionally diagnose major depressive disorder, and then you can put the patient on follow-up and see. You don't have to wait till the whole florid syndrome comes out. Okay. And it will be very disabling. The patient will find it very difficult to sleep. Vegetative functions will be affected, sleep, appetite, and a social functioning, interpersonal functioning, occupational functioning. The student may be unable to study, he's unable to concentrate, he's unable to study, he starts failing in exams. So that is when we call it a disorder. So the dysfunction is there, the distress is there, the symptom cluster is there, and then we make a diagnosis. In oncology or in palliative care, what happens is these physical symptoms, like we said, there is fatigue, there will be weight loss. All these can happen due to malignancy also. So how do you go about that? So we have something called an Endicott substitution criteria, where these physical symptoms are replaced by psychological symptoms. That is that is given in your module. We focus more on the psychological symptoms because the physical symptoms could be part of the illness, malignancy also. Okay. It actually depends on the clinician's judgment also. There are different ways of approaching it. Somebody does an inclusive takes in all these symptoms and try to make a diagnosis. Somebody excludes the physical symptoms and make a diagnosis. Somebody tries to substitute these physical symptoms with psychological symptoms and make a diagnosis. So sadness is not always depression. Anxiety is not always. Anxiety is adaptive in many cases. Because we are anxious about the exam, we prepare in advance. But the anxiety level shouldn't cross the optimum so that you are totally dysfunctional. So anxiety otherwise is adaptive. Basically, it is an adaptive phenomenon, but it overshoots and it becomes dysfunctional. The person becomes dysfunctional. You make a diagnosis of a disorder. Now, Anju wants to know whether to put all the patients on antidepressants. That is more of an ethical question, Anju. I would leave it to your clinical judgment. You think you can go through the modules and you can think of the possibility of this depression. There are couple of drugs which can, chemotherapeutic agents which can induce depression, steroids. Again, everything is not psychiatric also. Sometimes hypothyroidism, sometimes radiotherapy exposure, radiation to the brain. So all these can produce behavioral symptoms. So whenever you make a psychiatric diagnosis, use the criteria as well as use your clinical judgment to find whether there are underlying medical causes that is contributing to this, and whether there are substance induced issues, whether it is related to an addiction. So all those things are common guidelines in making a psychiatric diagnosis. It would be far too much to say that put all your patients on antidepressants, but definitely when it is indicated, when you think your patient is going to do better on antidepressants. You discuss with them, and I mean, these patients, they trust you, and they'll definitely come out with all these suicidal thoughts and all these things. Only thing, we shouldn't get very shocked, or we shouldn't get very upset. uh, it's all part of it, as yet another illness which you got to identify and address, so that your patient gets the maximum quality care. The quality of life of your patient as well as the family improves. Okay.
Okay. So I think we can wind up the session. Our time is up, and
Okay.
I request all of you to go through each modules before you come for live discussion. Only then you can make maximum benefit out of it. So thank you, Dr. Anju, for joining us today. Even
Thank you, sir. Thanks,
you were
everyone.
not, uh, even if you had a very hectic schedule today for the last few days, but still you were able to find out time. And thank you everybody for
Thank you, sir.
joining us. Lakshmi, it's over to you.
Thank you, sir. Thank you, Dr. Anju. Thank you all for joining us today. We can see you with another discussion on next week. Till then, bye.